Thank you for joining our Debbie's Dream Foundation Curing Stomach Cancer webinar on the role of nutrition for cancer patients. When diagnosed with cancer, nutrition becomes even more important. Good nutrition can help you feel better, reduce the risk of infection, keep your strength up, and help you heal faster. During this informational webinar, you will learn the building blocks of a healthy diet, as well as the nutritional needs throughout treatment. I am Mary Margaret Kilmeyer, and I will be moderating today's webinar. I am the Program Director for Debbie's Dream Foundation Curing Stomach Cancer. I am a licensed marriage and family therapist and recently completed my doctorate. My clinical and research background is focused on working collaboratively with doctors, patients, their families, and members of the healthcare team. We would like to thank Genentech for providing funding to make this webinar possible. We would also like to thank our promotional partners, the American Association for Cancer Research, the Anti-Cancer Club, Canadian Cancer Survivors Network, Cure Magazine, the Esophageal Cancer Action Network, Meals to Heal, and Patient Resource. You will be able to ask questions during this presentation. You can type your question into the white text box that appears on your screen. At the conclusion of this presentation, we will address questions as time allows. In addition, the recording of this webinar will be accessible on our website in approximately 1 week. First, I will introduce Debbie Zellman, who will share with you her journey and information about Debbie's Dream Foundation. Then Rhone Levine will present nutrition for the cancer patient. And then there will be a time for a question and answer session at the end. I would now like to introduce the president and founder of Debbie's Dream Foundation, Debbie Zellman.
Thank you, Mary Margaret, and thank you to all who are listening. I am the president and founder of Debbie's Dream Foundation Curing Stomach Cancer, and I was diagnosed with stage 4 stomach cancer in April of 2008. At that time, I was only 40 years old. I was the mother of 3 young children, married to a physician and a practicing attorney with my own firm. I had no risk factors for stomach cancer, and my symptoms were very vague. I was told that my chance of being alive in 5 years was only 4%. However, I'm happy to tell you that it has been over 7 years since my diagnosis. However, I have had 5 recurrences, and I'm still a patient. Next slide. In April of 2009, which is a year after I was diagnosed, I started Debbie's Dream Foundation Curing Stomach Cancer. We are a member of the Deadliest Cancers Coalition, the Patient Equal Access Coalition, the State Patient Equal Access Coalition, and One Voice Against Cancer. I am also on the National Cancer Institute Esophageal Gastric Task Force, the Patient Advocacy Steering Committee, the NCCN Gastric and Esophageal Guidelines Committee, the CVMRP Department of Defense Peer Review Cancer Research Program, Programmatic Panel, the ASCO HER2 Testing Guidelines Project in Gastric Cancer, and the American Cancer Society Research Program Stakeholder. However, I'm told that most notably, I appeared on Dr. Oz in a program about stomach cancer. Next slide. So just some brief facts about stomach cancer. It's one of the leading causes of cancer death worldwide, second in men and fourth in women. Most people are surprised to hear that statistic. However, each year, almost 1 million people worldwide are diagnosed with stomach cancer, and approximately 700,000 of them will die. In the U.S., Americans are diagnosed with stomach cancer, and more than 11,000 will die. Stomach cancer is on the rise in young people ages 25 to 39. However, per cancer death, stomach cancer receives the least amount of federal research funds of any cancer. When I was diagnosed, there were very few resources and support services for stomach cancer patients, and most people knew very little about this deadly disease. Next slide. So we at Debbie's Dream Foundation are trying to change that. We are raising awareness about stomach cancer, advancing funding for research, and providing education and support internationally to patients, families, and caregivers, all the things that were not available when I was diagnosed. DDF seeks as its ultimate goal to make the cure for stomach cancer a reality. Our website is www.debbiesdream.org. Next slide. I'm happy to tell you we have reached many milestones in just over 6 years, and all of the resources that we offer are free, including our Patient Resource Education Program that we abbreviate PREP. It prepares patients, families, and caregivers. And they can be from anywhere in the world, and they're matched with other survivors and caregivers using very specific disease criteria, as well as other criteria such as their stage, their biomarker, their gender, their role, their region, and things like that. In addition, we offer free symposia and webinars throughout the year. We have 29 chapters in the United States, Canada, and Germany, events across the United States and Canada, and we have given $350,000 in research grant funding. We've also made a significant impact on federal research funding. We've held 3 Capitol Hill advocacy days about stomach cancer, as well as a Capitol Hill briefing, the first of its kind. In addition, we are so proud to tell you that solely due to the advocacy of Stream advocates, we were successful in getting stomach cancer added to the Department of Defense peer-reviewed cancer research program pot of money, which is $50 million. That's going to make a huge dent, we hope, in stomach cancer research funding. Going back to the website, we are so proud of it. It contains in-depth stomach cancer information. It also contains a lecture library, which is where this lecture will be housed probably in a week or two, clinical trial information, as well as a matching service, a stomach cancer support community that I really want to encourage all of you to be on. It's a fabulous support community that really is so well organized and easily navigable, and better than any social media sites that you are on currently. We have blog topics and resources, and our website is completely translatable into more than 60 languages. Next slide. So here you get a little glimpse of the homepage of our website. Very easily navigable, you know, if it's an event that you want to attend, if it's the information and support that I referenced, it's under the information and support tab. You can read all about us and our amazing board of directors, our grants that we've given out, or grants to apply for, any news, how to take action, shopping for periwinkle merchandise, how to make a donation, contact us. So I'm going to turn it back over to our wonderful moderator, Mary Margaret Kilmeyer, who can explain more about how to get involved. Thank you.
Thank you so much, Debbie. As you can see on your screen, there are many events to get involved in and that you can support. This coming Saturday in Chicago, Illinois will be our Stomach Cancer Education Symposium and webcast. This is a completely free event for you to attend either in person or to log into that webcast. It is taking place this Saturday in Chicago, Illinois. We are hosting experts in the field of gastric cancer. You'll have the opportunity to ask questions, whether from the audience or if you log in interactively, you can type your questions into the webinar that you would be viewing. Then on Sunday, November 8th in New York is our New York Night of Laughter. And all this month, of the month of November, is Curing Stomach Cancer Month. And there are many opportunities and events that are going on across the country right now, all throughout the month, that you can get involved in. So please check our website under the Events tab to find out what events are taking place in your area. On Friday, November 13th is the International Stomach Cancer Jeans Day, and this is a great way for you to raise awareness by wearing jeans either to the office. A school club or an entire school or organization can support by wearing jeans, making a small donation, and then donating that money. Donations for that can be made directly to Stream Foundation, and it's a very fun way to get involved. And then on January 24th, we will have a team participating in the Miami Marathon and Half Marathon. Stream Foundation is headquartered in Plantation, Florida. Our office is open from 8 a.m. to 5 p.m. Monday through Friday. On this slide, you will also see important phone numbers and email addresses to contact our office. We will now start the presentation on nutrition. Our presenter is Rhone Levine of Meals to Heal. Rhone is a board-certified oncology dietitian and has worked in cancer centers for the last 18 years. She is an advocate for cancer patients and seeks to develop access to oncology dietitians for all patients. She is an author and national speaker on oncology, specialty nutrition practice, and a past chair of the Oncology Nutrition Dietetic Practice Group, and of the Academy of Nutrition and Dietetics. We're very pleased to have Rhone with us today, and at this time, I will turn the webinar over to you.
Hi, and thank you everyone for being here today. Thank you to WStream for giving me this opportunity. My goals today are to review the common concerns that patients experience after gastric surgery, normal function of the digestive tract versus altered function after surgery. Want to stimulate some ideas and strategies regarding maximizing intake, nutrition, and quality of life. And lastly, review some ideas to get some enjoyment out of the holidays, as we often focus on food and eating at our holidays, and people after gastric surgery may feel that they have less to look forward to. So we're going to talk a little bit about that. Eating is one of the things that we take for granted in our lives, and the journey of diagnosis, surgery, treatment, and then healing can be lengthy. For many people, anywhere from to a year and a half before the normal process of eating and digesting eases and becomes less like a job. So I'm using the slide to describe it as it's like climbing a mountain. This picture of Mount Hood in Oregon, please take notice that there is an uphill, but there's also an easier downhill side once you reach the peak. And I often tell my patients that the further you get from surgery, the better. So I am going to ask people to have patience with their recovery process and work on the strategies we're going to be talking about to help ease their symptoms and maximize their nutrition as well as their quality of life. Next slide. This slide describes the most common concerns that people report after partial or total gastrectomy, including a very severe lack of appetite, which is the term that we use in the medical world is anorexia. The feeling of being or getting full very fast after eating, even after a couple of bites or a couple sips. And this term that we use is early satiety. Another symptom that people may have is chronic indigestion or reflux, and it can become a very severe reflux to the point where people describe it as constant burning. Chronic nausea or queasiness, dumping syndromes, which we're going to talk about in a couple of minutes, as well as improper digestion or malabsorption of nutrients, leading to a sense of fatigue, weakness, and a chronic weight loss. And over the long term, vitamin and mineral deficiencies. We're going to talk more about that in terms of survivorship. Next slide, please. So it leaves people following their surgery in a frustrating place, and each one of these complications can occur by itself. It can occur in combination with other challenges, and it may come and go depending on situational factors. So it can be very confusing, and the symptoms and the challenges can literally become so complicated it's hard to sort them out. So the types of things that we look at when we're trying to sort this out is the type of food that was eaten, the type of fluid that was consumed, the volume of food or liquid consumed at that time, as well as background features. So for example, somebody's personal fatigue level, as well as concurrent cancer treatment that's going on. Next slide, please. I want to just talk for a minute about where we start. And so let's understand first what you're recovering from. And what I recommend to my patients is to review your surgical records and talk with your physician. So find out what is gone in terms of anatomy, but also what is still present. So, for example, if you've had a partial gastrectomy, which part was removed? If you've had a total gastrectomy, it's important to understand what reconstruction you have had. And when we talk about the function of the stomach, there's a lot of different functions. So depending on the surgery that you've experienced or the treatment that you're going through, the function can be very altered. So just starting with the concept of the valves control the movement of liquid and food through the body. At the top of the stomach is the gastroesophageal valve, which prevents the refluxing syndrome. At the bottom of the stomach is the pyloric sphincter, which drips the ground up food at a nice slow rate called pacing into the duodenum, where most of the absorption and nutrient absorption occurs. The primary function of the stomach is to act as a holding vessel or reservoir to hold the bulk of food or the large volume of food that we consume at a meal, and then over time grind and mix the food with the stomach acids and then break down the food into small tiny bits so that we can start absorbing the nutrients. The other thing that the stomach does is it works with and communicates with other organs. And so, for example, the gallbladder, which helps to emulsify fat so that they can be digested and absorbed, and the pancreas, which helps to digest carbohydrate, protein, and fat. So the communication can be lost or mistimed with those other organs after surgery. Next slide, please. Much of the management that favors quality of life and improved food tolerance occurs then by implementing behaviors that mimic the functions of the stomach. So the stomach is usually performing these things, and once we have an altered stomach or have the stomach removed, we need to use our behaviors to manage and mimic these functions. And these are the common post-surgical instructions people receive to make their eating easier. Many people will describe these instructions as a full-time job, and I've heard that repeatedly from patient after patient. And it becomes almost like a complex time management project. So for example, we have the weaning process off of a tube feeding. For many people, they'll still have a tube in after surgery onto oral intake. We have a restriction of using very small amounts of food. For some people, this may be a total of 4 ounces of food and liquid per eating session. We have this concept of 4 to 6 small meals each day, frequent intake, and using almost like a schedule to time it out throughout the day. We also have the recommendation to take liquids between meals. So now we have meals every couple hours, and we have to put the liquid in between. And they have very strict guidelines often of 30 minutes to 60 minutes between, after and before meals. So if you can imagine, you almost have to put this onto a chart, as well as the concept of avoiding simple sugars or sweets, limiting things that are hard to digest like cream or fat or fried items, as well as limiting insoluble fiber or roughage. Next slide. So it's important to pay attention to what you are experiencing. And it helps us as the medical team to decipher and identify the clues and to help you to move more towards normalcy. So it does help to keep track of and to answer these questions. Ask yourself these questions. What food or liquid do you tolerate best? Which ones do you tolerate worse? What situations do you find you are not tolerating food? What are the symptoms of intolerance? When do these symptoms occur? Is it right after you eat or drink? Is it later on in the day? Is it after you take a nap? Or when you get up in the morning? As well as documenting stooling characteristics, which basically means that after you've had a bowel movement, taking a look at the character of the stool, and then looking for symptoms of maldigestion. We're going to be talking more about that in a couple minutes. And then lastly, it does help to keep a record of time and volume and to answer these questions, because these are the clues that help your team to understand what's happening. Next slide, please. I chose this picture of a cafeteria brawl to describe what I often hear from or hear about the family dynamics that occur around eating after surgery. So the doctor is telling you need to eat because you need to heal. The family is loving you with food. They're trying to be on your team. And at the same time, the patient just absolutely has no interest in eating. They just don't want to eat anything. So I chose this slide to describe the feelings of frustration and stress that many people experience. Does this sound familiar in your life? Next slide, please. And the issue is that most of our lives, we can't wait to eat. We're always hungry. We want more. We go to bed at night dreaming about what we can eat next. And so eating is just a natural easy process. Next slide, please. Until after we've had surgery. So after surgery, this feeling of always wanting to eat is gone, at least temporarily. And we need to examine the factors that affect us after the surgery. And also for some people, of course, chemotherapy, radiation, and continued treatment. Our overarching goals are to protect quality of life, to continue with the recommended treatments as prescribed by the doctor, and to prevent malnutrition and weight loss. And so we are going to talk about, what about the holidays? When you think about and plan for Thanksgiving or other holiday meals, you think of an entire table laden with special china and filled to the brim with food, weighed down underneath a gigantic turkey. But let's not forget the rest of it. We can also focus on not just the food, not just a special meal, but the friends, the communion, the family, the conversation. So there are lots of ways that we can look forward to our holidays. Next slide, please. And so what if food is just a necessity? You need to cook again to get the title here. I took this slide at the Smithsonian Institute, and this is a picture on the right-hand side of the original astronaut food, which was clearly, looking at it, used only for survival in space. So what do we do? How do we address this? How do we approach this when food is literally just a necessity? And this is the experience that people feel when they are recovering from this type of surgery. Next slide, please. It's like a constant struggle, as people describe it to me. And this is a common scenario described by patients. Patients tell me that they worry about eating all the time, or that mealtime is just very stressful, or sometimes they'll say, I'm just waiting until I get hungry, or I'm just looking to find something that tastes good. But this is the scenario that occurs at home. And so the spouse says, what do you want to eat? And the patient says, nothing. And so what we do is we change the question from what do you want to eat to, for example, what do you think you could tolerate now? Do you see how that's a different question? And so it stimulates a different answer. So what do you think you can tolerate now? Well, maybe a peanut butter cracker, or maybe a piece of cheese. So you can see how it's different. Another helpful strategy that people use is that they'll keep a list of foods that are tolerated sometimes. And I always kind of describe it, it's like, I don't know if it's because the wind is blowing or because the moon is blue, whatever it is, but you keep a list of these foods that kind of work. And it helps people to ease that feeling of, I can't think of anything to eat. So you can keep this list on the refrigerator and you can run your finger down the list. So it might start out there's only 3 things on it, but over time you'll find there will be 12 things on it or 25 things on it. You run your finger down the list. No, I don't want that. No, I don't want that. Oh, you know what? I haven't had this for a while. I think I could have a particular dish. Next slide, please. And you need to click again to get the title, please. So one of the most common things that people experience is the sensation of anorexia, or no appetite and feeling full, early satiety. And people just describe that nothing sounds good, they're just not hungry. So the most effective thing that we can do is to schedule small, frequent intake, because you can tolerate small amounts better. And although we aren't necessarily hungry, we can still get in the food. Another strategy we use is we pair tolerated foods with other items. And a good example I like to use would be cheese, a small piece of cheese, and a small cracker. Another thing we can do is we can use convenience items. We can carry things with us, so that perhaps it's something as simple as a granola bar in your pocket. Convenience items might be frozen meals that you can keep in your freezer, so you don't have to actually prepare a meal when you aren't particularly hungry. You can just pick out something that sounds tolerable and then have it readily available. You can choose high-value items in terms of calorie or protein, so making sure that we're getting in that nutrition even in a very small volume of food. You can choose liquids that have nutrition content. Sometimes it's easier to drink than it is to eat. And also you can use distraction to increase oral intake. It's sort of like all of those behaviors that we try to avoid when we're raising children. So you can turn on the TV and use TV to distract you. You can watch a movie. You can read something. You can have a conversation. I've had patients that tell me that they can't eat anything at home, but they go to a holiday party and they find they can nibble. So just enjoying distraction to help you to eat. Next slide, please. Next, I want to discuss dumping syndrome. And this occurs in about 15 to 20% of people that have had a partial gastrectomy and about 50 to 70% of people who have had a total gastrectomy. And the dumping occurs when the body senses a concentration of food in the abdomen, and it panics. This is my word using panic, but wanting to thin down that concentrated food. So what your body does is it pulls fluid out of the rest of the body and then floods the digestive tract to thin it down. The consequence is a rapid shifting of fluid out of the blood supply into the digestive tract, which literally drops your blood pressure, raises your heart rate, and at the same time can, in some situations, even lead to explosive diarrhea right after eating. The triggers tend to be things like simple carbohydrates or sugars, large volumes of food or liquid, hot or cold temperatures, and sometimes just concentrated nutrients. Next slide, please. One of the best resources I wanted to share is found from a University of Virginia Digestive Health Center, and these resources are available free and available online. The website is www.gi, so the letters GI, and then the word nutrition.virginia.edu. So it's www.ginutrition.virginia.edu. And these are patient materials on how to eat with tips and ideas to eat after gastrectomy, after dumping syndrome, and other symptom management that you may find helpful. So I actually always tell patients to share this information with their providers and their physician as well. And so just talking about dumping syndrome, early dumping is described as 10 to 30 minutes after a meal, and patients experience both the vasomotor and GI symptoms, meaning abdominal bloating, nausea, cramping, diarrhea, as well as perhaps flushing, dizziness, cold sweat, tremor. And then the late dumping is described as 1 to 3 hours after a meal. So you can see how finding out the timing is really important when we're trying to solve these problems. Some people will experience both a version of early dumping and late dumping. The late dumping is described by more vasomotor symptoms and as well as an intense desire to lay down or recline. I've had patients tell me that they literally start looking around wherever they are for a place to lay down, including, for example, and you can imagine how upsetting this is, but even at like the grocery store. And so you can see how quality of life-wise it's really important to get a handle on these things. One of the things I like to make people aware of with dumping syndrome is that oftentimes these symptoms do improve as the digestive tract learns and develops new function over time. For many patients, again, the further from the surgery, the better. In 6 months to a year and a half, these things tend to resolve. And generally, it continues to improve during that time frame. So when I'm saying a year, things are getting better during that time frame. So don't feel that this is a hopeless kind of situation. Next slide, please. The types of strategies that we use for anti-dumping is to, first of all, identify and avoid the triggers, and then really focusing on volume control of solids and liquids, and then really limiting those simple sugars, so switching to using more complex carbohydrates instead of sweets. And then physical positioning can also be really important in limiting movement after meals. So a lot of times I'll have people finish their meal and then sit in a recliner for a half hour just to relax and allow the digestion to occur without stimulating a dumping. Other things that might work are simply cutting the portion of that risky food in half. So taking the 4 ounces of the milkshake down to 2 ounces, for example. Using soft or blended textures for some people will help. Using protein at each meal, so peanut butter, egg, cheese, meat, so that we can actually slow down this process. Next slide, please. Other factors that influence appetite significantly include nausea. Next slide, please. And I like to talk to people about nausea because I found that many people interpret using anti-nausea medications or prescription anti-nausea medications from the doctor to use it only when vomiting or when they feel like they're going to vomit. But in reality, in this situation, it's very appropriate to be using these medications underneath the care of your physician, even if you are just experiencing queasiness. So this kind of queasy, icky sensation that people have is very appropriate to be treated with medication. So just thinking about also taking a look at what works best. It's actually soothing to your digestive tract to have very small but frequent intake. Avoiding odors, cooking odors, food odors, and this is actually one of the recommendations is to use cold plates or cool foods, cool liquids, and of course they don't have odor, so they're less likely to stimulate nausea. Using convenience items if preparation causes nausea, using easy to digest foods or bland items that just don't stimulate a lot of attention from your body. And using starchy foods. Also, flavors that are tart and sour are very appealing when people have nausea. I know that sounds kind of funny, but so using pickle, for example, on the side of a sandwich might be helpful. Next slide, please. Another symptom that people describe is having very severe reflux or heartburn, and this is very much more common when the gastroesophageal valve has been removed. In other words, there's nothing to stop the bulk of food from flowing back upward up into the esophagus and up into the throat. Generally speaking, it's more likely to occur when people have overeaten or been overeating. And so overeating can be something that's very small. It could be that you exceeded 5 ounces or 6 ounces at a meal. So it's important to know what your limits are and to work with them. Some people notice, for example, that they can eat larger portions early in the day and then smaller portions later on in the day. Another thing that can encourage the refluxing is by using liquids at meals. So again, we're trying to push the liquids in between meals. And the reason we do that is the more liquid your food is, the more likely it is to flow the wrong way. We also avoid foods that increase discomfort. This could be caffeine, acidic foods, greasy foods, spicy foods. And then again, we use the positioning to just use gravity to help keep the food down. And this is where people sometimes are told to, even when reclining, to be positioned so that their pillows are raising their head, raising their chest, so that it's higher than the rest of their body. It's also possible for some people that they are describing a phlegm that kind of gets caught in the esophagus. And it's the body trying to help with the digestion once the stomach has been removed. And so some people describe this kind of slimy phlegm that can even be foamy and that they can't get rid of and they can't eat until it's cleared. And so there are medications that sometimes help with this. And so it's important to incorporate your doctor and tell your doctor what symptoms you're experiencing. So for the reflux and the heartburn, certainly topical barrier type medications may be helpful to just coat and ease this sensation, but also medications that help pull this or weight these secretions down, which might be fibers that you can take or mix with your food to help to reduce that sensation. So very important to incorporate this discussion and talk with your doctor. Next slide, please. And then the last major symptom I wanted to talk about was fat malabsorption. So fat malabsorption has symptoms that include loose stools or diarrhea, light-colored stools, floating or voluminous stools, as well as greasy stools, quite a foul odor. And then also people notice it as just very gassy, bloating, belching, just very uncomfortable, discomfort after eating. People describe it to me that it trains them to not eat. And this may be the result, again, of loss of communication between your body and the gallbladder and the pancreas. So we just aren't getting the right messages through to those organs that help us to digest these fat nutrients. Some people may not have any overt symptoms. It might just show up as weight loss. So even though they're eating, quote, unquote, enough, so that they're eating what they used to eat, they still find that the weight is just trickling off. So this might mean that they just are not getting the value out of some of their nutrients. So the way that we deal with this is you can be tested for pancreatic exocrine, which is just the term for the enzyme insufficiency, and what we do to treat it is have people use capsules that have pancreatic enzymes in them that are taken at meals. And so these pancreatic enzymes then are taken during the meal, mix in with the food, and then help you to address that digestion. Next slide, please. And I wanted to just talk about the survivorship concerns and late effects. Late effects is a term that we use for after treatment is completed, and it, for many people, it's a lifetime monitoring that needs to take place. And so vitamin and mineral deficiencies may take up to a year to develop after the surgery. And so it's imperative that patients are aware of this long-term monitoring that's required to protect their health. It's very important to think about these monitoring, especially for the vitamins, the B12 vitamin, folate, and iron. And if you are no longer seeing or not seeing regularly your surgeon, perhaps you're seeing your family doctor, it's important to bring this up with your medical team so that it's on everybody's mind. You may require annual testing, and it's very common to need supplementation of these nutrients to ensure adequacy. And some people even require monthly B12 injections to stay healthy. In addition to this, if you have fat malabsorption, you might be at risk for fat-soluble vitamin deficiencies. And so over time, for example, A, D, E, and K, those are the vitamins that are fat-soluble, they might need to be supplemented. You might need to be tested for them. And regarding the long-term, bone disease occurs in about 18 to 44% of post-gastrectomy patients over a long period of time. So this means that you're more at risk for fractures and bone pain due to decreased absorption of calcium and vitamin D. And the important thing to know about this is we can prevent this. It's very possible to prevent this. And so again, talking with your doctor, do you need to have a DEXA scan to watch your bone health annually or every other year, just to make sure that you aren't having problems with osteoporosis over the long run. Another issue I like people to be aware of is that with medications, so perhaps it's oral chemotherapy drugs, perhaps it's prescription medications, even over-the-counter medications that you take, that your absorption may have changed for that medication. So that it's important to keep that in mind so that you are thinking about discussing this with your physician. Is it possible that you would absorb it better after gastrectomy instead of having the pill form to have a medication that is a liquid, for example? Would it be more likely to be absorbed better? Next slide, please. So I'm going to just kind of summarize some of the things that we've talked about. And so these common recommendations help post-gastrectomy patients to feel better and to eat better. And actually, this is a picture. It's not the greatest picture. I took this actually up at Penn State. There's a diner up there, and they have this dessert. And you can see I have it next to a bazooka gum, but it's called a teeny weeny. So this dessert is literally 1.5 ounces big. And so it's a wonderful end to a meal, and their motto is always, there's always room for a teeny weeny. So normal dessert side, and really cutting the size of it to the point where it's just a couple of tastes, and that might be something you can tolerate better. On the other side of the slide here, I have these sliders, which is just a very small, portions for the meal. So you can enjoy a meal, but very small portions. Next slide, please. And then watching the clock, and I realize that clock is flipped backwards. My husband just pointed that out. But to set yourself reminders, so don't wait until you feel hungry. Do not wait until you are ready to eat. And so, because that time frame might be 6 months from now. So you're going to schedule yourself, perhaps every 2 hours, perhaps every hour and a half, perhaps every 3 hours to be eating and drinking throughout the day. Next slide, please. And then making your liquids and your fluid to count more than just hydration. So all liquids are hydrating, but not all liquids have calories. So this is an example of a smoothie. I made this at home. It actually is green, but it actually tasted really good. But using, very small portion nutrition drinks, low sugar smoothies, soups, homemade popsicles, things like that to give you calories as well, and potentially protein, as well as hydration or fluid. Next slide, please. This is an example of pairing well-tolerated foods with other food groups. So this might work well if you are trying to draw in more food. Let's just say that you tolerate an apple well. Well, then maybe you pair it up with a piece of cheese or a cracker and cheese and grapes. So you can draw yourself or lead yourself into eating more variety. Next slide, please. This is actually this is a picture of homemade fudgesicles. So using non-traditional meals, this can actually become a meal. And you could make your own lower carbohydrate, lower sugar treats. Next slide, please. And click again, please, to get the title. So enjoy cooking for others and trying new things. So you may revisit the things that you always used to enjoy about food. You might enjoy exploring recipes, exploring cooking, new techniques, cooking for other people. So you don't have to give up on those things. And by participating in your normal activities, the things that you normally enjoy, you might find that it draws you into eating. Next slide, please. Enjoying seasonal fresh foods, so take advantage of the seasonal foods to draw you into more variety. Next slide, please. Focusing on the enjoyment you might have from growing a garden and perhaps growing an herb garden. Herbs add to your nutrition as well as to the flavor of your food. You might find that fresh produce may tempt you. And I have in here, this is actually from my garden. This was, I like to grow flowers, and so putting flowers on your table, which enhances your environment and de-stresses your eating environment. So just taking advantage of things that you have always enjoyed. Next slide, please. And it's perfectly okay to stick with what works. Comfort foods have often stood the test of time when people didn't feel well. And traditionally, or perhaps it's because they get digested more easily. So don't be afraid if you are repetitively sticking with the foods that we might consider to be comfort foods when you don't feel well. Next slide, please. And taking a look at your recipes. So all recipes can be modified. So you can take your lovely, cherished family recipes and work through them to enjoy the essence of what you're used to. But make changes in the ingredients that might make you not feel well after gastric surgery. So one of the recommendations I have is to start with what's already been done. So look at cookbooks, look at websites for recipes that are similar to your family recipes and perhaps modify from there. A simple Google search for diabetic recipes will offer thousands of recipes from which to choose, which might be lower sugar. So even if you don't have diabetes, you might benefit by these recipes. They've already done the work for you. Next slide, please. And then thinking about the holidays. So the last thing you want to do over the holidays is make yourself sick at the holiday meal. And your approach to this can impact your well-being and your enjoyment. So the first step I have is to make a plan to eat very small portions over a long period of time. So almost, if you think of it in terms of taste testing the foods or sampling the different foods, the different recipes. Then, so maybe start with a bite of the turkey and gravy, a bite of the mashed potatoes, and then wait a half hour or an hour, and then try the cranberries and the sweet potato, and so on. Another thing to keep in mind with your holidays is that chewing thoroughly and slowly is actually going to help you to tolerate the meal better. The third thing is that you must stop when you feel full, so that when you get that sensation that you are going to overeat, you need to be stopping. And thinking about it, we enjoy leftovers and leftover meals after the holidays. So just think of that as part of your plan, that you might have this at the meal and then your leftovers might be, 6 hours later, and you'll try something else at that point. On the pictures that I've chosen off on this slide just represent an example of a menu that might be tolerated better, and I just pulled up online from the Eating Well website, shallot roasted turkey, cider gravy, cranberry sauce that was made low sugar, pecan roasted sweet potato without the extra simple sugars in it, green bean casserole but made with caramelized onions and mushrooms instead of canned soup, mini pumpkin custards that are made with sugar substitutes so that they don't have excess carbohydrate in them. Next slide, please. And so this next slide is a recipe of green bean casserole being redone. And so what we've done is we've reduced the carbohydrate, which again is oftentimes the trigger that causes dumping syndrome in people, to less than 6 grams in a 3-ounce serving. So in a small serving, 6 grams of carbohydrate, and if you were to cut that in half and do just literally like a spoonful, you'd be down at about 2.5 grams of carbohydrate. Next slide, please. And this is another redone recipe for like a pumpkin custard. So instead of the pumpkin pie, this might be something that you would enjoy instead, and it can be made with a sugar substitute. And so just an example here, this is about a 1/3 cup of this recipe would bring the carbs down, or the carbohydrates down, to about 6 grams. So again, very tolerable, not likely to cause a dumping symptom. Next slide, please. So I want to just conclude with this, that digestive tract adaptation varies by individual. Most patients find that symptoms continue to ease progressively over the period of 6 months to 18 months after surgery, and that there is a rainbow at the end of the rainstorm. So be patient with yourself, care for yourself during this time period. Be vigilant, pay attention to the symptoms that are occurring, talk with your medical team, talk with your dietitian about what you're experiencing, and you'll find that over time that things have gotten to the point where you're really able to eat much more normally. And so that concludes my presentation. I want to thank you for your time and consideration today, and thank Debbie's Dream for this opportunity.
And thank you, Rhone, for joining us today. We are actually a little bit over time for this segment as well, but I did want to select one question for you to answer. In consideration of the holidays, aside from portion control, is there any other tips that you might provide for someone who's visiting family and it maybe doesn't have as much control over their schedule and agenda and meals?
Well, a question, and I think it is very appropriate to talk with family, or talk with people who are inviting you over for a meal. And it actually, if people have a severe symptom, I think it's totally appropriate to even potentially bring something that they know that they can tolerate. I would also mention that it's important to focus on what else we can do besides food. And an example would be just really focusing on the enjoyment of the conversation, time with people, just focusing on the other things that are not food related. Regarding the other holidays, in terms of gifts, for example, that people might enjoy, I like to remind people that there's all kinds of things that you could tolerate. For example, nuts would be, perhaps like a gourmet nut package, a gift certificate for either a store where they might need to purchase convenience items, or purchase, for example, vitamin replacement, even something as simple as like a mini blender for making smoothies. So there are a lot of different options for people to be able to enjoy their holidays.
Excellent. Thank you so much for that response and for your presentation today.
All right. Thank you.
As you know, this webinar was brought to you by Debbie's Dream Foundation Curing Stomach Cancer. Thank you to our speaker, Rhone Levine of Meals to Heal, and to Genentech for providing funding that helped make this webinar possible. As you see on your screen, we have many upcoming events for you to get involved in and support. Details about these events are available on the Debbie's Dream website at www.debbiesdream.org. Thank you to all of our listeners today. This concludes the 12th in a series of 12 webinars on nutrition. Please send your comments to patient.resource@debbiesdream.org. Thank you for joining us.